Okay, it's 1 o'clock. Welcome to the ICBT Friday Training Group. This group is a group of dedicated clinicians who has now grown worldwide, and we're all in different stages of learning how to implement ICBT. We're learning from each other in consultation and in these groups. It's a wonderful group that is generous and really helps us to integrate these approaches. Today's presentation is going to be recorded. So there'll be a question and answer time at the end, and there'll also be opportunities for you to post questions in the chat. And during the presentation, it'll be paused to answer some questions. Please refrain from presenting client-specific questions because this presentation will be posted in the ICBT website, which is open to the public. So we wouldn't want any confidential information to be recorded. And it takes a lot of time to edit it out when it is. So sometimes we get caught up in the discussion and forget that we're being recorded. And I just want to remind you of that. So I think that is all of the introduction for the welcome. But I want to introduce our speaker today, who probably needs no introduction, but Frederick Aardema is the co-founder of Inference-based CBT. He has been instrumental in bringing it to the United States, along with several members of this group. I think we will be forever grateful to have this new approach, evidence-based approach, to help our clients bring healing and health. So without further ado, I will introduce Frederick Aardema.
Thank you, Margaret. I'm just going to start sharing my screen. I think I'm allowed to. Am I allowed to?
Yes.
Let me see where it is. I don't see it right now. I got it. Everybody can see it?
Yep. Yes.
Yes.
All right. So I will be presenting today, which will be on some initial findings from a treatment trial that we have been conducting in the past few years, comparing ICBT with ERP. So it will be mostly a research presentation, but I hope it will have some immediate practical implications as well for everyone, in terms of better understanding your own outcomes with your clients, but also how to better interpret the outcomes of treatment trials. I will try to take some pauses in between for questions, if time allows for it. So do not hesitate to ask questions in the chat if anything is unclear, because it can get a little bit technical. I like to make sure everybody understands it. So going straight to the main theme of this presentation, when the gold standard fails, exposure and response prevention is a first-line treatment for those with OCD, and it significantly improves symptoms in a majority of patients. Often you hear the number 60 to 70%, but it does have some limitations. One of these limitations is that it requires prolonged and deliberate exposure to fearful stimuli, and so it can be a difficult treatment for clients. And this exposure and these difficulties may lead may affect acceptability, treatment refusal, and dropout as well. Also, when we talk about 60 to 70%, we have to be clear about what that means. Because most people, the majority, fails to reach remission, and often residual symptoms remain, which are associated with relapse. It's also a non-specific treatment for OCD that assumes OCD follows a phobic model of development, and this has been criticized by several people, including myself and Dr. Kieran O'Connor. It's also not always suitable for all subtypes. It was developed in the 60s, 1960s, or 50s even, mostly for contamination and checking. And it had to be adapted for those, especially for those with unacceptable thoughts and repugnant obsessions. There often were no overt compulsions with techniques like imaginal exposure, etc. So to deal with these limitations and to overcome them, an inference-based approach to OCD was developed. And I won't go deeply into the clinical aspects of this, but just briefly, because most of people know, and we have other presentations that go into that. But it conceptualizes obsessions first and foremost as inferences of doubt, produced by a dysfunctional reasoning style, which is what we call inferential confusion. And because of that, inference-based cognitive behavioral therapy is primarily a cognitive therapy that treats OCD as a reasoning or a belief disorder. And for the same reason, it does not include prolonged and deliberate exposure, and so it may have certain benefit in comparison to ERP. We already know from previous trials, and we had several, including at other labs, there's no statistical difference between I-CBT in comparison with ERP and standard CBT. Standard CBT being usually the appraisal model in combination with ERP, with a total of 4 completed randomized controlled trials, and a total N of 363, if I added it up correctly. So 360 participants so far in several trials that we have conducted. But it's important to keep in mind that when you do not find a statistical difference in trials, and very few people are fully aware of this, non-significance does not establish equivalency or non-inferiority. And I will go into that in more detail and explain it. And especially when there's no significant difference, and you have reason to assume that there may be certain benefit to a new treatment, you perform a non-inferiority trial. And you could compare that to the field of medicine. Let's say you have a particular medication, a pill for a disease, but it comes with a lot of side effects, right? So, and then somebody comes out with a new pill and it says, yeah, similarly effective. There's no significant difference, but it has certain benefits. In that situation, you have to prove that it's non-inferior and that it has these benefits. And that's what we're doing with this trial. So based on that, we had the objective to establish with this particular trial whether I-CBT is non-inferior and has benefits in comparison to ERP. Hypothesis 1, and these hypotheses were set up a priori, registered with the Library of Medicine of the National Institutes of Health. I-CBT is non-inferior to ERP. I-CBT is more acceptable and easier to adhere to. And I-CBT is associated with lower treatment refusal and dropout rates as compared to ERP. Those were the principal hypotheses we had. We have more, which I won't go into in this presentation. But this is the data based on the, don't forget, this is preliminary analysis. This is what we looked at right now, okay, or recently. Just any questions so far? I don't see the chat, so I don't know. But any questions so far?
There aren't any in the chat, Fred.
Okay, good. So don't hesitate if something is not clear. Happy to answer in between. So for the method, eligibility criteria, primary diagnosis of OCD according to DSM-5 criteria, established through a structured clinical interview. No change in medication during the 12 weeks before treatment for antidepressants, 4 weeks for anxiolytics. You want people to be stable on medication in a trial and preferably not change medication either during the trial, if at all possible, because it can lead to a bias, you know, unless everybody changes. But so you want to keep track of that too. No evidence of suicidal intent, which would have to be treated first in a different setting. And for the same reason, no evidence of a psychotic disorder. Sample size, when we did this analysis already a few months ago, so we have more now, but at the time, 112 participants diagnosed with OCD. Our objective, like I said, it's preliminary initial finding, but our objective is 160 in total. Seems like a big number for a trial, but that's what you need if you're going to do a non-inferiority trial. You need a lot of power in order to be able to prove your hypothesis. You need power to start with. So it's not in a regular superiority trial, as we call it, we just look at is there a statistical difference or not, then you need generally less people. Non-inferiority trial, you need a lot more. That's why you don't see these trials often. They're expensive and they take a lot of effort. Trial design, parallel group randomized controlled trial comparing the outcome of 16 weekly sessions of I-CBT compared to 16 treatment sessions of ERP in OCD patients. Delivery, the same, obviously, in terms of treatment durations, etc. Randomization, ratio of 1.1 performed by an independent statistician. Allocation sequence concealed. No one in our team had an idea of the allocation sequence of who the next person was who would get ERP versus ICBT. Prevents those type of biases. Diagnosis and OCD severity established by independent evaluators blind to treatment modality. So during the interview, the evaluators did not know which treatment the person had in the course of the trial. Also, again, important for preventing biases. And our main instruments for diagnosis and severity was the structured clinical interview for DSM-5 and the Yale-Brown Obsessive Compulsive Scale. So Yale-Brown Obsessive Compulsive Scale, probably most of people know it, instrument of choice, also often called the gold standard. Many people don't like it. I don't like it that much either, but it has a lot of benefits as well because it's an instrument that is used by almost every serious trial that is conducted on the Y-box. And the benefit of that is that we can compare outcomes between trials, right? If everybody uses a different instrument, it gets difficult, it gets really difficult. So that's the benefit, a big benefit of the Y-box. It's sort of internationally recognized and it allows for easy comparison. Well, not always easy, but it allows for comparison between studies. Which brings me to my next point. Also, an outcome measure is clinical status after treatment. So what is treatment response? What are the treatment response rates? And what are remissions rates? And these are often based off the Y-box. Okay. The problem with that is that there is no real consensus as to what defines treatment response and what defines remission. Everybody uses different cutoff points across trials often. And so sometimes the outcomes between different trials are different. I mean, the outcomes may be the same, but the percentages that are reported are different because of the use of different cutoff points in terms of how much people, what percentage of people had this much treatment response and what percentage of people remitted, right? So what we did, we based it off one of the latest, it's already a few years ago, but cutoff points based on an international expert consensus of around 350 experts in OCD, which I believe is an advancement in terms of using cutoff points that are recognized and that we have consensus about. And this work was done by Matai Cole and colleagues. And those are the cutoff points we used, which is Y-box change, response rate or treatment response defined as a Y-box change greater or equal than 35%. Remission Y-box post smaller or equal than 12 posts on the Y-box. And Margaret uploaded an article on this, and I advise you to have a look at this because I think it will help you interpret trials in general, but also for use of your own clients, where you could say, okay, you seem to be in remission, right? It's a message you want to tell clients and how the treatment ultimately performed for them. Okay, so this is what we use. And yeah, just to add to that, if, for example, Y-box change is defined as greater than 20% improvement, then of course these numbers of treatment response differ, right? They start changing. So this is what we use there: 35% and remission smaller or equal than 12.
May I ask a question about the method, just about the training of the therapists in each of the treatment arms?
Yes. What's your question? Whether they were trained or?
What was their level of training and what was their affiliation? Was this, all with your group, or were there multiple sites, or how were they selected, and what degree of experience or training did they have with each of the treatment?
We had different levels of training. Often you see a lot of trials where it's 1 versus 1 sometimes, which of course then therapist bias becomes a problem. In our case, we have around like 6 therapists, but of course it changes because these trials take many years, an influx and an outflux of therapists at times, but they were all trained in the modality. They were all supervised. They had an allegiance to the particular treatment that they delivered. And they were of varying experience, which was matched and kept equal for both treatments.
Thank you.
And
then I wondered if you had considered the Y-BOX-2 at all as a treatment outcome measure, rather than.
Yes, I have considered that. Well, I don't even know. Well, it was probably before this trial already available. I have considered that, but the problem with that is, again, how do you compare this new Y-BOX with the other trials, right? So what ideally we should have done, and I'll probably do that in our next trial, is do both. Yeah. So, but I didn't add it to this trial, the Y-BOX-2, because it has a different range. The Y-BOX-2, I think you're talking about the one. Was it Storch who developed it?
Yeah.
Yeah. Okay. Yeah. No. So we did not use that. It has a wider range and it's a little bit more sensitive. That Y-BOX version for severe OCD. But no, that's its benefit. But no, we did not do that because it would complicate the comparison with other trials. But if I would do it, I would add it as an addition. Does that answer your question?
Yes, thank you so much. Yeah.
You're welcome. So our other measure was treatment accessibility, an important one for us, for our third hypothesis, treatment acceptability and adherence, developed by Milosevic and Radomski, which measures acceptability of a treatment and anticipated adherence. So that's items like, it will be distressing for me to participate in this treatment. I will be able to complete this treatment. And we use this measure throughout the trial. Excuse me. Then another measure was dropout and treatment refusal rates, which was also an important outcome measure for us, although preliminary in this case because the N is quite small yet. What we also included were COVID-related measures because in the course of the trial, COVID-19 came along, which was a big deal for us and for everyone. April 2020, I think it was the same for the US. COVID emergency measures came about, which meant that there were so many incoherences in the trial. With some patients were seen face-to-face pre-pandemic, and others via video conferencing during the pandemic, up until now. Then the second incoherence was that some patients were seen pre-pandemic and others during the pandemic. So to protect the internal validity and the coherence of the trial, we decided to exclude all COVID-19 pre-COVID participants. And we were able to do that because COVID-19 occurred fairly early on in the trial, with only 11 participants having completed treatment in person. Right? So otherwise, we would not have done that. But it was easy to say, like, okay, we're going to exclude these people from the main analysis. We updated the trial registry. So we now have a new context, a more coherent context. This is a randomized controlled trial conducted during a pandemic, video conferencing for everyone. But we also added COVID measures to control for threats to the external validity, because if you're familiar with the literature, when COVID-19 started, there was a lot of talk about how is this going to affect ERP. Maybe COVID-19, maybe ERP doesn't work that well anymore during COVID because of that you couldn't properly expose the person, right? Even in some guidelines, it was mentioned maybe you have to only do medication in certain cases because you cannot do ERP. Now, a lot of people did not agree with that, but it's a valid concern. It's a possibility, right? So how do you control for that? That's why we added these measures in order to control for any potential differential impact of COVID-19 on the treatment, right? And I'll get back to that later. So with a lot of work, we had to go online, etc. We had to computerize everything, but we were able to get very far in that trial. We assessed 135 people for eligibility when we did the analysis. We excluded 23 for not meeting eligibility criteria, 23. Randomized 112, and like I mentioned, 11 from those excluded from the main analysis. We'll look at that in the additional analysis, but from the main analysis, they're excluded. And this led to 50 people being allocated to ICBT and 51 being allocated to ERP. And like I said, we're still recruiting, trial's not done yet. We expect to end up with like 80 versus 80. Treatment of refusal and dropout rates mentioned there. I'll come back to that later. Any questions so far?
You answered the one question that's been posted in the chat.
Okay, good. So I'll ask more about this because now it gets a little bit technical. All right. So what we did is an intent to treat analysis with a linear mixed model to test treatment effects within and between variables on the outcome measures. It's just a statistical technique, a modern one, a recommended one these days to use for a treatment trial to test for outcome. What is more important here is the idea of non-inferiority and the non-inferiority margin that we use. Because when you do a non-inferiority trial, you set a priori, ahead of time, you set a predefined non-inferiority margin. And a predetermined margin, or a non-inferiority margin, is a predetermined margin of difference between a new treatment, in this case ICBT, and a standard treatment, in this case ERP, that is considered acceptable for the new treatment, ICBT, to be considered similar or not worse in comparison to ERP. Okay, and there are different ways to set these margins. You can do it by consensus. The better method is, in my mind, is to do it statistically. And there's a method for doing so, which is the 95-95 method followed by Shumio-Wittes. And I will go into how we did it statistically. There are specific guidelines for that. It's based on meta-analysis and how ERP performs in comparison to control conditions. But it translated to the requirement of no more than a 2-point difference between treatments on the Y box. And I think this represents a non-substantial clinical difference, consistent with the notion of non-inferiority. And it's important to keep in mind, when we talk about a 2.4 difference, we're not talking about the observed mean difference that you observe in a trial from beginning to end, not the observed difference. It is the lower limit of all possible estimated values of the true difference, which we call the 95% interval. So when you do a trial, you don't get just a mean difference between treatment, like mean difference on the Y-box. You don't just get a mean, you get an estimated mean. And surrounding that estimate mean is a 95% confidence interval of all potential values that you could have if you would do the trial several times, 10 times. You sort of get this range. So you get sort of a confidence interval of what you can be confident in that the true mean falls into. And when you have a non-inferiority margin, it reverts to the lower limit. And I'll get questions. I'll take some time for questions later, but maybe it clarifies more with the next slide. So these are some hypothetical scenarios of what outcome could be in a non-inferiority trial. The top one is not something we hypothesize. The top one would be if ICBT would not be non-inferior to ERP. And why is it not non-inferior to ERP? It's because this green line, which is the confidence interval on the top, exceeds the non-inferiority margin of -0.24. So these are potential values You have an estimate, you have an observed value, and observed means somewhere in the green line, but there's a confidence interval. Statistically, you establish this based on the variation in the scores. It can exceed, and in this case, it exceeds the non-inferiority margin. So non-inferiority would not be shown in that case, if that is the actual confidence interval. The second case is what we did hypothesize, which would be when ICBT would in effect be non-inferior to ERP. And it isn't non-inferior to ERP in this case, because the lower limit of this confidence interval does not exceed the -0.2.4 non-inferiority margin. Then there's a third scenario, which would be superiority, as they call it, right? It's a little bit of a strange term, but we call it a superiority trial. If there would be a clinical difference, one treatment clinically, or not clinically, significantly performs better than the other, then you would say that that treatment is superior. So that's what a confidence interval would look like if a treatment is actually significantly better than the other. We did not hypothesize that, like I said before, because we already knew from previous trials there is no significant difference. What we wanted to establish was non-inferiority and that it had benefit. Is this sort of clear to everyone? Other questions?
So,
Yeah,
go ahead.
I just dropped a question in the chat about the 2.4 difference. Are you talking about a 2.4 difference on the Y box?
No,
T16?
no, exactly. No.
Yeah, I'm not clear on what you're talking about here.
It's the lower limit. So, for example, it's a lower limit of possible values. Because if you do a study, you get a mean difference that could be, for example, a score of 1 or a score of -1, right? -1, it would favor standard ERP a little bit, but it's still only an estimated value because you would do multiple trials. That value may be a little bit different, right? So that's why you have a confidence interval, which tells you have this observed score of 1 or -1 or whatever it may be. But what we're really interested in, how confident can we be of the range of potential values, the true mean, if you would do the trial several times. That's why you get a confidence interval.
Right, I understand confidence interval.
Yeah. So the -0.24 is the lower limit of this confidence interval, of the entire range of values that you could get doing the trial multiple times, but not necessarily the observed mean.
Right. So you're looking just at the lower limits of the confidence intervals.
To make sure that the confidence interval does not exceed it. If it would exceed it, then you can no longer be 95% certain, with a certainty of 95%, that if you would do the trial again, that the mean may not actually be lower than a -2.4. I mean, it can fall anywhere, but you just don't want it to fall. Don't want it to be lower, or the lower limit of the confidence interval to exceed the non-inferiority margin. And when I show the results, it probably will become a little bit clearer even than that.
Perfect, thanks.
Okay.
Brad, there's another question in the chat.
All right, yeah, go ahead.
Not quite related, it goes back a little bit. Jeremy asked, were the providers of the interventions from labs that favor ICBT in clinical training programs? And how did you address researcher allegiance to the model as a demand characteristic?
We had an independent person, we have an independent person that is going to look at treatment integrity, who does not have an allegiance to ICBT. The training is from different places in Montreal, you know, so we hire different people to do our therapies, you know, and sometimes trainees, but they were supervised by people that had an allegiance to one particular approach. You know?
So does that mean that some of the clinicians, there's like evidenced allegiance to ERP, the ERP providers?
Yes, yes.
Okay.
Yes. I mean, sometimes things change, and then that's how we started out. And sometimes what we did do is that a person started providing a treatment for both in some situations, okay, where a person was first in both and there was not a real allegiance. But in general, the therapist had an allegiance to each or were first in both approaches. And what you do then, we tape all the recordings and we have raters, independent raters, who then say, is the treatment applied correctly? And is this really ICBT? Is there no cross-contamination between the treatment, etc.? There are two ways to do trials. Sometimes you do it by allegiance only. One therapist is assigned to one treatment only, which we did in a majority of cases. Or sometimes you also have therapists who do both treatments. You know? And there are benefits and negatives to both. And there's still a debate ongoing as to what is the best approach, you know. But for the main part, what we did is that people only did one treatment and had allegiance to one only. Okay.
Thank you, Fred.
Part. Okay. Okay, good. So let me get to, okay, so this was the outcome in terms of just change on the Y box. I-CBT, so no superiority, and that we expected that. I-CBT, pretty strong effect size, 1.9, ERP, an effect size of 1.6. So both ERP and I-CBT were associated with significant reductions in symptoms, large effect sizes. Actually, from a statistical viewpoint, these are super large effect sizes, right? But what is statistically super large is not always clinically super large. So you have to differentiate between the two. But these effect sizes, in comparison to meta-analysis with ERP and other sort of treatments, are into the middle of upper range of what is found in meta-analysis. So we did not underperform. We actually outperformed in so many ways. So, but no significant difference, like I said, which we expected. For treatment response and remission, also as expected, no significant difference between ERP and I-CBT. So clinically meaningful response and 51% for those with ERP and 60% in I-CBT. And again, this seems a little bit lower than the numbers you open here, right? But the 60, 70%. But it all depends on the cutoff point that you use. Okay, so if in this study we use a cutoff point based more on, sometimes it's called a reliable change index, then these numbers would be higher. But treatment response, sort of like experts agree, okay, this is substantial. The person did respond to treatment at 35% or more. We're at 51 to 60%. Remission rates, 12 and lower, less than that, 42 to 48%. So less than 1 in 2 people who get ERP or I-CBT actually remit. And again, these effect sizes are not different from other meta-analysis. Our main hypothesis, I-CBT is non-inferior to ERP. And this is the confidence interval we have now with the sample size that we have now. All things being equal, with more participants, this confidence interval is going to narrow a little bit more. Okay, all things being equal. But what we have here is an observed mean difference of, meaning the actual observed difference is 0.97, so one point in favor of I-CBT, but that's just a number, right? So that's actually observed. But what is important here is how much confidence we can have that we will observe the same mean when we do another trial. And that's the confidence interval. And that stays above this non-inferiority margin of -0.24, with a range from -0.2.16 to 4.3.
No, dude.
Sorry? So that's the range, all right? So we confirmed the hypothesis. You know? Non-inferiority is demonstrated because lower limit of the CI does not cross and exceed the non-inferiority margin of -0.24. The treatment acceptability and adherence. We confirmed the hypothesis as well. ICBT was significantly more acceptable and easier to adhere to at all of the time points. T1, pre-treatment, T8, not pre-treatment, first session actually, T8, mid-treatment, T16, post-treatment, at all the time points. And interestingly, ERP actually significantly reduced in acceptability and becomes more difficult to adhere to over time. Anybody has any idea why?
The whack-a-mole effect, because more obsessions are popping up or different themes?
Could be. Could be. What about the hierarchy?
Oh,
They're going up to the higher part.
This was actually important to mention. We did not do ERP according to the inhibitory learning model, where sort of like start mixing things up, you know. So people were in a hierarchy, and yes, the exercises do get harder. So we're speculating based on this data. You cannot say like, okay, we know for sure that is why that is, but this would be one possible explanation, you know. Significant difference, and we think it's important because these scores, we had a quick look at it, but it's temporary at this point. It's a little preliminary, but they did relate to outcome. So the more acceptable the treatment was, the better the outcome of the Vibox at T16. Okay, but we want to do some more refined analysis than that in the future. But there was a significant difference in terms of treatment acceptability between the treatments. Treatment refusal and dropout rates, also still quite preliminary, given the, especially here, given the numbers, right? Because in order to detect differences here, you need larger numbers. But from a numbers perspective, which doesn't mean that much, higher treatment refusal and dropout rates for ERP as compared to ICBT. But a trend for more combined refusal and dropout rates in ERP, and the trend is a significance level of less than 0.10. Normally it's 0.05, right? So, but it's preliminary, like I said. We'll have to look at this again when we have more power, a bit more people recruited and participated. So, like I said, or let me go back. Any more questions?
Yes, Fred, there's a couple of questions in the chat. The first one was the ERP treatment manualized. Were there cognitive or ACT aspects in the manual?
Yes, it was manualized, and we used the manual by FOA. It had to have some adaptations because obviously the treatments had to be equal, you know. So we did it similar to other trials where we had some practice in the session and outside of the sessions. Not home visits, for example, you know, that sort of thing, because ICBT did not have that either. But it was standardized according to a specific manual. What was the other part of the question?
Well, were there cognitive or ACT aspects in the manual?
No. There was psychoeducation, a little bit of psychoeducation, but there's in any treatment, ERP as well, right? According to the manual of FOA. But no, nothing cognitive, no ACT, none of that. No.
So
we wanted to give pure ERP.
Gotcha. So Lucy comments, I wonder if ERP is also more difficult in adherence because exposures can become compulsive.
Yes, I mean, yes, but I would not necessarily see any difference with ICBT, but the same would apply in all fairness, you know. Okay. So, yeah.
And Molly has another question. I'm going to let her unmute and ask that question.
So if you don't mind, you talk about the mean difference in Y-box scores, and I just want to make sure I understand what you mean. So you're talking about the mean difference in time 1 to time 16 scores in the ERP group compared to the ICBT group. Is that correct?
Yeah. Not just at post, right? These are estimated means where you get an estimate. This is the difference. So it controls for what is at pre, you know. So
Okay.
you understand what I'm saying? So it's not just a simple calculation by hand. This
Right.
is where we use LLM, a mixed model, you know?
Right.
Yeah, this is the observed estimated mean of one where ICBT has, numerically speaking, performed better. By
Okay,
1
so
point,
approximately
by 1 point.
about 1 point better and change.
Yeah, which was not significant as we expected.
Okay, and then
Right?
that confidence interval around that.
Yeah, exactly. And this confidence interval, because you set a non-inferiority margin ahead of time, you
Mhm,
want this confidence interval, at least if your hypothesis is confirmed, this
mhm.
confidence interval should not exceed this non-inferiority margin, which you also established statistically. And at that point, you can say, well, you can have confidence that you're going to find this again, you know, and with a 95% confidence, you know, and that's what you want with it. Again, if I do the analogy of a medication, you want to be sure that's not just a fluke, right? You want to be 95% sure that that it never performs less than a certain margin that you set, you know, and that's what we're doing here. You know?
Mhm. Okay, thank you.
And yeah, this is not done. These type of trials are not done often because for the reason I mentioned, I'm not aware, I could be wrong, but I'm not aware of any trial with ERP versus another cognitive therapy where a trial like this is done before. It just focuses on significant difference or not on non-inferiority. So that is new. But I realize the concept of non-inferiority can sometimes be difficult to grasp, but I hope people get an idea of what it means. So yeah, so like I said, I have a look at the time. Yeah. So what I said, we added COVID measures, right? In order to we wanted to make sure that ERP got a fair shot here, right? Because COVID came along, and that also ICBT got a fair shot because who knows? I mean, we assume that COVID-19 may particularly impact ERP because of the exposure exercises, right? But it also could impair ICBT, concentration, difficulty sleeping, cognitive insight, who knows, right? So we asked therapists for each client to start rating a lot of different things. And I'm only going to present some of them. We have a whole battery of these questions, but I'll just cover the most representative ones, which was to what extent do you think that COVID-19 could, meaning at T1, or just interfere with the therapy your client is currently receiving? So we asked that at different time points, and no significant difference for each client was established and rated by the therapist, and actually quite low in the scale, right? A little bit, but they didn't find it to be interfering. We asked clients the same thing. To what extent do you think that COVID-19 could interfere with the therapy you're currently receiving? Again, no significant difference between ICBT and ERP at any of the time points in the treatment. All right. What we did find was interesting. There was a significant increase in perceived interference for ICBT from T8 to T16. I'm not exactly sure why. Maybe people become more aware of how COVID impacted them, maybe more aware in ICBT. Either way, there was no significant difference between treatments, which is what matters here, okay? Another measure, to what extent did COVID-19 interfere with the conceptualization and planning of homework and exercise for your current client? And again, no significant difference between treatments at any of the time points. Now, we did find a small difference, and it makes sense, that you have to adapt homework and exercises for your client due to COVID-19 in accordance with social distancing guidelines and other recommended safety measures. And ERP required more adaptation in homework and exercises as compared to ICBT at T1 and at T8, right? And that makes sense, right? I mean, during COVID-19, you're not going to devise an exposure exercise where you tell your client to start hugging a person on the street, for example, right? So that didn't make much sense. So no interference it was not experienced as interference, but ERP did require some more adaptations in exercises to adapt to these safety measures and these social distancing guidelines. And we looked at whether this was related to outcome, and it was not. Another question, did your client experience difficulty doing exercise because of fear of contracting COVID-19? And no difference again. Same for clients, no significant difference. So overall, in terms of, let me just go back. Any questions on this?
There aren't any questions in the chat box.
Okay, thank you. So overall, in terms of our general conclusion so far, ERP and I-CBT delivered via video conferencing are effective treatments during a pandemic. That's what we can conclude for sure. The effect size is 1.6 to 1.9 and in the medium range of meta-analysis for CBT. We also found is I-CBT is non-inferior to ERP. I-CBT is more acceptable and easier to adhere to. And there is a trend for I-CBT to be associated with lower combined refusal and dropout rate. But this is still preliminary. And no evidence of a differential impact of COVID-19 interference during treatment. So likely results are generalizable outside of a pandemic. And that's a good thing because COVID-19 will probably be around for a long time, and ERP is effective under these circumstances. But I-CBT provides those with OCD with an additional and a more acceptable treatment option. At the same time, I think it's very important to admit that there's still a very significant proportion of those with OCD who do not reach remission with either I-CBT or ERP. So we're still far from where we want to be. Less than 1 in 2 people actually go in remission or recover from OCD, whether this is I-CBT or ERP. So that brings me to a new trial, which is what we are thinking, what we're currently piloting and thinking of doing next, in order to maybe actually get to improved outcomes for those with OCD in comparison to what each individual treatment is able to accomplish right now. And it's based on the idea that perhaps rather than do this head-to-head comparison, which treatment is more effective than the other, you know? Maybe we should look at different treatments being effective for different people, meaning people respond differently to different treatments. That's a hypothesis. We don't know whether that's the case, but I think it's worthwhile to investigate it, because if that is the case, then that can actually lead to improved treatment outcomes better than what we have now. You know? And this is a design that looks at that, designed for a new trial. So that's ERP as a run-in treatment. Start giving everybody ERP. Sort of like the real world, most people first get ERP, right? But not everybody gets better. So around 60%, at least, that's what our trial shows, non-remission status. I mean, they improve, but you cannot say that they're OCD free, right? So 60%. Then what we want to do is randomize them to either inference-based CBT or ERP. And what we hypothesize, what we hope for, I think in both cases there probably will be some additional improvement. What we hope for, that we get a real effect where I-CBT can provide additional improvement, more so. We hypothesize it to be more so than ERP. So it's not a matter of which treatment is better than not, or to pit one against the other, right? But it's about maximizing the benefits of each individual treatment, by maybe eventually, maybe even ahead of time, being able to match the treatment with the individual. Because this could also go the other way around. Maybe ERP is better for some people than I-CBT. We don't know. That's not what we're looking at here, because this sort of reflects reality that we have right now, the reality we're in. This is our next trial, or at least we hope so once we get the funding. And that is the end of my presentation. Any questions or discussion?
Brad, is it okay? There's a couple of questions in the box. Molly's asking a great question. Are you continuing to do all of the treatment online now, or are you doing more in person since we've opened up more?
Yeah, we're going to continue. Good question. We are going to continue online, and there are several reasons to do so. All the data that has come out, and we already knew that for evaluations, that are just as reliable online as in person. But what has become quite clear with the evidence we have now, that video conferencing is as effective as in-person therapy, right? So there may be certain people may have preferences, but the studies seem to show it's as effective, you know. And I think so many people will continue to do treatment online anyway, so it reflects reality as well. And there's a lot of practical benefit. You can just imagine for doing a trial as well. It would not be the first consideration, but it's an added benefit. When you do a trial like this, I mean, we live in a big city, it's Montreal, but even then recruitment gets to be a lot easier once you do conferencing, because the net sort of like widens considerably. You can start, suddenly people can participate in a trial even though they don't live in the big city, and they live somewhere else and they have internet access, you know. It's also an equalizer in that terms, economically for people, you know. So yes, we will, for those reasons, all of those, we will continue with video conferencing in the future, because it is the future.
Mhm.
Yeah.
Thank you.
Lori, I think you've really pretty much addressed this, and y'all are doing more research on, would the subtype be a factor in which treatment works better? And it sounds like that's what your next research project is going to address.
Subtype, yes. Okay, so that's always that's a good question, and it's always something you want to look at, but it's not something we hypothesized a priori. And the reason we are going to look at it, you have to realize that for every subdivision you make in these type of trials, every additional question that you ask, you lose statistical power to be able to answer that question. So if you take a whole group of people with OCD together and you start them subdividing and start looking at outcomes by subgroup, you lose statistical power, and it will be harder to tell whether there is actually a significant difference or not. So whatever analysis we will do, and we will, it's going to be more exploratory than this sort of the hypothesis I showed earlier, which you register a priori if you do it right. You don't change your hypothesis in the course of a trial, etc. You know, you register it a priori, and then anything else that you on top of that is more exploratory.
So Mary asked, did you measure any therapist effectiveness? Like if some therapists had higher outcomes than others?
No, that is something that we can look at, whether there are differences or differences in therapist effects, and we'll likely will do that, you know. But it's not something I've yet looked at. No. I don't want to scare our therapists.
And Susan kind of asked, therapists were evaluated according to adherence to the manual, correct?
Yes, well, we started doing that. Like I said, this is preliminary data, but we started doing that in a subsample, and we'll do more, you know, to ensure. But they're also being supervised, right? So we have a continuous look at adherence, but we'll also look at it in terms of doing it by independent raters as well, to look at adherence to protocol.
And are you publishing the preliminary data?
No. This is just for presentations at this point, and we'll publish the final results. Because don't forget, because it's a analysis not on the whole sample yet. This is preliminary. Okay, so things can change. I don't expect so, and that's why I've for some things we are more preliminary than others. But let's be clear about that. It's not the total sample yet. But this is the direction it definitely is going in, right? So it's preliminary findings.
This is a great question. Will you be expanding the age of participation to include teenagers? Which I'm hoping.
It requires a separate protocol, right? Requires an adaptation. So it requires a separate study, I would say. So it's not just a matter of expanding. Well, expanding within a one study, I would analyze it separately. That's what I mean. And it would be a separate application as well, because it's quite different. It's a separate type of protocol. Especially it also depends on the age a little bit that you go to. But I would love to, but all these things depend on funding.
Right. So Molly has the last question. I'm just going to open it up to her on the floor. We only have a few minutes left. So Molly, if you just want to ask your question.
I was just wondering when you thought that you would be wrapping up your data collection, like when do you think you'll be done with recruitment and the treatment
I
trial?
think this year we'll be done with recruitment. But then there's still the follow-up, another 6 months.
Mm-hmm.
So I think in terms of writing up the study, we're looking at the end of 2004, publishing it. If everything goes well, it has to be submitted, the analysis has to be done, etc. But yes, I hope to start this new trial earliest in the fall of this year or next year, but we'll see. It all depends on funding, like I said.
Very interesting. Thank you for presenting this. It's exciting data.
Thank you.
Mm-hmm.
So anyone else that wants to jump in and ask a question, we have a couple of minutes left.
I'll just jump in for a sec. I'm curious if the new trial would go up against the inhibitory learning model or POA's manual again.
Oh, good question. I was just talking about that with someone, and I want to have a trial that reflects the situation on the ground. And the habituation model is still probably the more prevalent one. On the other hand, you also want to look at, like, where are we going towards this? So that's a consideration as well. So in that sense, I lean towards the inhibitory learning type of adaptations. And it would be interesting because really there are no trials with inhibitory learning yet. So that would be the first, so that would be fun too. But I have not decided yet.
If anybody would be interested in joining me to present some of the data that we have on ICBT at the IOCDF conference in July, please let me know. I'll make a comment on this video when it pops up. I don't know when you expect to have it on the group site, but I've asked a few people to help, but if anybody would want to, anybody interested in this, I'd really appreciate that.
Fairly soon, I hope. Yeah.
Molly, I was thinking, like, would it be possible instead of having a panel, maybe you just like present the ICBT data instead of like having it where there's like a panel discussion?
Yeah, I mean, that's certainly possible. I could talk more about that. I don't want to hog all the time, but I guess my underlying motivation is to sort of bring the field together. As I see, there's a lot of, I think, I can't remember who it was speaking at the beginning about how emotional it is that people respond from emotion when they're challenged to change their way of thinking around things. And I think that causes us as professionals to lose a sense of humility, and you lose a sense of openness and innovation. And we start to encamp and divide when that's the last thing our field needs. There are already so many people not getting effective treatment for OCD that if we can find other alternative routes to help them, we need to do that, and not be so married to a certain way of thinking that we close off options for being better as therapists. So that was my goal in putting everybody up there together, to get some of the bigger names and in current treatment, especially ERP, to sort of be humble about what we know about ERP and what we don't know, and that, like, there is data, there is evidence base for these newer treatments, and And at the same time, we still need, more evidence. And as clinicians, making sure we're aware that I think we all have patients that we see have met their limits of what they can do with ERP, and help us understand that when we do a different route, what is this based on in science? Making our own clinical decisions from an ethical and enlightened, sort of knowledgeable place. So kind of accountability all around the table is what I was kind of going at, which is why I thought about, like, let's get everybody there. But an alternative of just presenting that data would also be, something that we could consider.
Molly, you seem really knowledgeable about research and about both approaches. I think it sounds like you'd be a great person to do that, honestly. Maybe you'll have somebody join you, but I like Teresa's idea too, to have someone who really knows what she's talking about and can put the information out there. It is 2:01, so I know other people will have to go on about their day. I'm gonna wrap it up. Ask Fred if he has any final comments, and just remind you, next week we'll be meeting back here at the same time to discuss module 3. So Fred, it was a wonderful presentation. I learned a lot.
Thank you.
Mhm.
Very
Well,
much.
thank you, Margaret. Yes, I second what Molly said. I mean, we're here for improving outcomes and improving outcomes for OCD, and that's frankly all I care about. So I'll second that.
Wonderful.
Thank
Great
you.
to meet many of you.
Thank you all.
Thank you, Fred. Appreciate it.